So I will be talking about using young donors for DMEK. We know that we have evolved over time, and DMEK has provided faster, complete visual rehabilitation and reduced the rate of immune reaction compared to DSEK. However, what has remained unresolved is the intracameral unfolding, which is little less standardized. Most of the critical steps and mechanical manipulations during this time is when we have the cell loss, which is about 35% cell loss in these patients have been reported. It is primarily because of the tightness of the scroll is more in the younger donors as compared to the older donors, that despite of the better endothelial cell count, we have still restricted ourselves to the use of the older donors. Hence, most of the eye banks prefer high donor age with higher endothelial cell count. Now, what has happened over time, and I'm glad John Batchman is here, right here, and there is some work which even they have published wherein they have used very young donors. There are also reports that, the temperature variations in the fluid in which the DMEK remains stored causes a difference in the scroll size, the tightness of the scroll of the DMEK tissue. Now, we had some key questions in front of us when we were trying to actually use the young donor DMEK tissues with higher endothelial cell count, because that's a large majority of tissue we get in the eye bank, and also using the tight scrolls was to answer these basic three questions: that why does the DMEK graft scroll? Why does the DMEK graft scroll always towards the endothelial side out? And why there is a difference in the young versus the old DMEK graft to scroll? So there is a work wherein you know that the composition difference is there between the infant and the adult human basement membrane. That is, that if you compare the young donor DMEK tissue versus the older donor tissue, the anterior banded zone remains constant. That is, after birth, that is the zone which remains always 3 micron. But it is the posterior non-banded zone which is secreted by the endothelial cells, which keeps accumulating and causes a difference in the thickness of the tissue in the young versus the old. Now, the anterior banded zone is composed of collagen 8, whereas the posterior non-banded zone is collagen 4. Hence, there is a difference in the ratio of the collagen 8 versus collagen 4 in the young versus the older tissue. Also, we know by this remarkable work by Professor Dua, who had actually gone ahead and studied the DMEK tissue, and he found that the elastin was lining the inner lining of the DMEK tissue. And he actually hypothesized that it is the elastin tissue which lines and causes the scrolling of the DMEK tissue always on the endothelium lying on the outside. And this is what is different in the PDEC tissue, wherein you have the collagen on both the sides, and that's why it doesn't scroll as much as the DMEK tissue. That was a theory that he had given. However, when we went ahead and we tried to dry up the DMEK tissue and observe it, we found that the DMEK scroll did not happen. It did not happen when it is get dried up. So this is the question: if elastin was the only reason by which the DMEK was going to scroll, why it was not getting scroll when it was without a fluid? We went ahead, we put in these experiments with Indian Institute of Technology in India, and this is the team who has worked up for these experiments. What they had done was to dry this tissue and then actually put fluid and see that the scrolling behavior only happened when the tissue was inside a fluid. It would never happen when it was without a fluid and air dried. They went ahead, they actually created this apparatus wherein they could photograph each DMEK tissue that we had provided them. They also created an analog with the chitin tissue, exactly like the DMEK tissue, and they measured the scrolling property of the DMEK tissue in the young versus the old tissue. What you see in the graph here is not only the amount of the scrolling, it is also the time period which this scrolling takes time. And what they found was that the DMEK tissue not only scrolled differently in the young versus old, it also was different when different fluids were added to it. You can see in the graph on the right that sodium chloride versus dextrose versus glycerol, all three scrolled this tissue in the different amount. The amount of scrolling was different. And they hypothesized this, that it is the diffusion coupled deformation phenomena that actually causes the DMEK tissue to scroll. And I'll just explain that the DMEK tissue, if you see, is different in the anterior versus the posterior part in composition. So the fluid gradient across the DMEK tissue is different in the anterior versus the posterior part. And this is this concentration gradient across the film thickness that results in displacement of the fluid and different bending of the anterior versus the posterior banded zone. Hence, the DMEK tissue, if you see, is actually the inner layer is scrolling lesser than the outer layer, expanding lesser, That's why the scrolling happens. These actuation characteristics are governed by the stiffness, the geometry of the film, and the diffusion characteristics of the solvent. And it was very interesting to see that it was not only that the difference in the fluid, but also the fluid composition differences in the percentage of the fluid composition differences caused a difference in the scrolling time of these tissues. Hence, we came up with this paper we had published with that group, wherein we showed that it is actually the diffusion coupled deformation phenomena which causes the DMEK tissue to scroll. Now, while we were doing this experiment, this is something for the clinicians, we kind of came up with some steps for preparing this tissue, and this is the technique that we came up. If you look at this, this is the double refined technique that we used in all 40 patients of the young DMEK tissue, which is 40 years and below DMEK tissue that we prepared. These are the usual steps, but there is one step which I would like to definitely share with everyone, was that if you see the separation of the tissue in the young DMEK tissue, there are too many adhesions of the Descemet's membrane to the underlying stroma. Hence, it is advised that when you're doing these separations, unlike in the adult tissue, wherein you can actually go beyond 1 mm inside the tissue while dissecting, in this you need to stay in the periphery all 360-degree until you have separated and broken all the adhesions. You can see the adhesions are so strong here. The second tip would be, you can see my left hand holding wherein very closely I'm trying to dissect. It has to be very close and sometimes almost peeling the Descemet's membrane when trying to break this, trying to separate the DMEK tissue. I would go ahead with these diagrams to which explains it better. And the third tip, which will be that when you're trying to pull in this Descemet's membrane, the young tissue, the force has to be tangential and not central. Unlike in the adult tissue, we try to pull the DMEK tissue towards the center. The force has to be all in the periphery tangential until, like you can see the diagram 8, that explains it very well. That's how if you are going to have a force, you can have very good DMEK tissue. This is unpublished data. We are still writing this study wherein we actually did 40 such tissues below 40 years of age. And we were successful in preparing about 76% of the grafts were prepared by this technique. We were able to actually dissect off very young tissue. Now, the second question that comes in using a young tissue for DMEK is how you're going to unscroll it. Then a very nice technique, that is Depina's maneuver, has been described wherein an air bubble can be kept on the top of the DMEK scroll, and that air bubble can be used to give gentle strokes to open up the DMEK tissue. We haven't done many clinical patients, but this is one of the patients of Fuchs dystrophy wherein a very young 36-year-old tissue was used, and we were able to get successful outcome in terms of graft preparation as well as the post-op follow-up has been great with this patient. The endothelial cell count has been very comparative to what you get in adult DMEK tissue. So with this, I would just like to summarize my talk by saying that there is a difference in the scrolling property of the young versus the old DMEK grafts. The physics which explains the difference in the scrolling property is the diffusion coupled deformation phenomena. That is what we are proposing. The graft preparation requires a different technique with modifications. We were able to get about 70% chances of success with a young tissue less than 40 years of age. And we agree that endothelial cell loss and longevity of the young DMEK tissue, we still need to test it in a larger cohort. With this, I would like to end my talk. Thank you for your attention.
Nidhi, that's lovely. We'll have to move on quite quickly to keep the session on time, but I will ask you one question that you can answer while you're sitting down. I'll come up to the podium. That is, how young is too young? Is there a lower limit for you?
Yes, I guess the youngest that we have done is about 26-year-old. But I quoted Professor John's paper wherein at least 17-year-old has also been dissected off in papers. So if you have a comment to say.
Yeah, so we try to use patient or donors at the age between 40 and 70 years. That's our normal range. So this happened by accident to use such a young donor, and I wouldn't recommend it for normal cases. However, I find it quite beneficial if you have younger donors with tighter scrolls, if you have a more shallow anterior chamber, because in those situations, if you have an old donor which almost doesn't scroll, it's not easy to turn it around if it's an old donor. So in some situations, it's more beneficial to have younger donors than older donors.